I think one area that stood out to us is the idea of trying to take a more personalized medicine approach or to look for enriched populations for certain endocrine abnormalities.
That this is a very promising area of inquiry, that we have a large amount of research literature that deserves to be studied, that deserves to be looked at, and there are already some actionable findings that are relevant for clinical practice.
That's Dr. Jennifer Dwyer and Dr. Abayas Aftab, who will talk about their review of hormone-based interventions for the treatment of depression. Their work appears in the August 2020 issue of the American Journal of Psychiatry. I'm Michael Roy, Executive Editor of the American Journal of Psychiatry, and this is AJP Audio. Dr. Jennifer Dwyer is an assistant professor at Yale University, where she's affiliated with the Child Study Center and the Department of Radiology and Biomedical Imaging. There, she is co-director of the Pediatric Treatment-Resistant Depression Program. Her work focuses on understanding the unique neuropharmacology of the adolescent brain and assessing novel treatments for severe pediatric affective disorders. Dr. Abayas Aftab is a clinical assistant professor in the Department of Psychiatry at Case Western Reserve University. He is also an attending psychiatrist at North Coast Behavioral Healthcare Hospital. He's interested in the psychopharmacology of mood disorders. In addition, he's actively involved in the exploration of conceptual and philosophical issues in psychiatry, and he leads an interview series on the subject for a major psychiatric periodical. Dr. Dwyer and Dr. Aftab are co-first authors of a review article in the August issue entitled Hormonal Treatments for Major Depressive Disorder, State of the Art. Dr. Dwyer, Dr. Aftab, hello and welcome to the podcast.
Thanks so much for having us.
Hi, Michael. Thank you. Glad to be here.
Now, your review article begins outlining how major depressive disorder is a common psychiatric condition, yet while there have been many kinds of treatments that have been developed for the disorder, many patients with major depression do not respond adequately to treatment. Could you talk about why effective treatments for major depression are lacking?
Yeah, I think the important thing for us to understand here is that major depression is what we call a syndrome, that it's an umbrella term that combines together many different things. So when we talk about major depression, we are looking at a very heterogeneous construct in which you most likely have a variety of different etiologies and pathophysiological processes that are going on. So when we are trying to treat a heterogeneous category or a heterogeneous construct, it's very difficult to develop interventions that would be effective in all instances of that disorder, just because the underlying processes are so different. And another relevant consideration is that even aside from the question of heterogeneity, if you look at the distribution of causal risk factors for depression, if you sort of like look at the things that contribute to depression and the way they're organized, these causal risk factors are spread out over a number of different domains, ranging from genetic factors, hormonal factors, neurochemical changes in the brain, to different kinds of psychological processes, ways of thinking, interpersonal relationships, and social factors. It's what the psychiatrist Ken Kendler calls the dappled distribution of risk factors. So, when you have a distribution that's so spread out, targeting just one area and expecting that it'll be effective in the majority of cases is not likely to be true. So that's why what's recommended is that when approaching the treatment of a condition like this, we have to approach it from many different angles, using biological agents, neurostimulation, psychological intervention, as well as social changes.
So there seems to be like a general agreement that more effective treatments for depression are needed. Now, your review article notes that one area that has appeared promising is the targeting of hormonal systems. Why have hormones been implicated in the pathophysiology of major depression?
Hormones have piqued people's interest in depression, starting with really early, careful clinical observations. So folks across the branches of medicine have noticed that the risk for mood symptoms increases during times of either hormonal upheaval or endocrine disturbance. So that can be sort of normal physiologic changes, so an increased risk of MDD in adolescence at times of puberty. in the postpartum period where hormones are fluctuating significantly, or during menopause. But then we also see that with more traditional endocrine disorders. So Cushing's syndrome is one example that people can look at, where there's an excess of cortisol, and that's been linked to depressive symptoms in something like 90% of patients. Similar reports with either increased or decreased thyroid function. So all of those endocrine disruptions have been linked with mood symptoms. And then we also see an increased risk when we give exogenous hormones. So for example, giving steroids for a variety of conditions has been linked with an increased risk for depression or even an increased risk of suicide. So all of those sort of careful clinical observations started getting the psychiatrist interested. And so the work that followed that really started investigating whether more subtle endocrine abnormalities could be detected in patients with sort of traditional MDD symptoms. And so there was a fair amount of work, for example, looking for stress hormone or hypothalamic pituitary adrenal axis abnormalities in those patients. And then finally, the basic scientists got very interested in looking at preclinical models and found that receptors for these hormone systems are enriched in some of the brain areas that we really like to talk about. So areas like prefrontal cortex or hippocampus or amygdala. And careful preclinical work suggests that these hormones play not just an important peripheral role, but a really important central role in the circuitry that underlies mood.
Okay, now you mentioned links to mood symptoms, and your article points to 3 particular parts of the hormonal system that have been linked to alterations in mood. Could you first identify what these are and then explain why you and your colleagues looked at these 3 systems?
Yeah, so the 3 hormonal systems that we are discussing in the article, the first one is the hypothalamic pituitary adrenal axis, also called the HPA axis. The second one is hypothalamic pituitary thyroid axis, or HPT axis, and the hypothalamic pituitary gonadal axis, or HPG axis. The reason we focused on these 3 axes is because these 3 axes are the dominant major players when it comes to hormonal signaling in the body. And so if you look at the many different ways in which hormones are doing their work in the body, their actions they're having, these 3 axes have a lot of impact in that. So naturally, when we are discussing links of the hormonal system to major depression, or we're looking at hormonal treatment options, we're going to be looking at these 3 axes just because of the dominant role they have. Another reason was that there are other hormonal axes and other hormones involved as well. Examples would include things like the melatonergic system or oxytocin. And when we were doing the background work for our article, we did look at some of these hormonal systems, but we realized that the research work in these areas was still at a very early stage and with very preliminary results. So we decided to focus on these 3 areas where most of the research work has been done and where we have some more actionable findings.
Okay, well, I'd like for us to go through each of these 3 areas in turn, and your article includes a figure for each that gives us an overview of it. So first, what role does the HPA axis have in the development and treatment of major depression?
So the HPA axis has gotten a lot of attention for major depression, both its pathophysiology and potential treatment. So we know that stress is important for the development and probably the maintenance of depressive symptoms. Many of our animal models for depression rely on paradigms involving chronic stress. So we know that stress is important, and the question is really, how is it important? So early studies studying patients with MDD looked for abnormalities in the HPA system. And there is a good chunk of data that suggests that there are derangements there, at least in a subset of patients. So the idea that there's sort of an overactive HPA system in depression and an impaired negative feedback. So in all of these endocrine systems, the end product feeds back to sort of shut down the production of the end product of the system. And so the dexamethasone suppression test, where you give a dose of a steroid and look for a reduction in cortisol, has shown abnormalities in subsets of patients with depression. The caveat is that it's not all patients with depression, and even some patients have shown hypocortisolemia. So it's certainly not something that applies to every patient with MDD and speaks to that heterogeneity issue that we've talked about. So that's one line of evidence, is from human studies. And then the second is really from a rich animal literature, particularly looking at corticotropin releasing factor, or CRF. So animal models have shown that if you increase CRF in specific brain regions, you can see increased anxiety-like or depressive-like behavior, which you can then abolish by blocking those receptors. So a lot of work has gone into developing small molecules that act as antagonists at CRF receptors, which is an area that we cover pretty extensively in the paper. The downside to that is that while we've helped a lot of animals with anxiety and depression-like symptoms, the clinical trials were not as successful as people had hoped. And so sort of the main impact of that line of work is that CRF antagonists have not panned out for MDD in a major way. There's still some idea about personalized medicine and maybe finding a subset of patients for which these compounds could be helpful. But overall, it was sort of a disappointment after seeing a lot of preclinical success and excitement.
Well, thank you for those insights. Well, next you look at the HPT axis. And what can you tell us about the relationship between the HPT axis and major depression?
So when it comes to the HPT axis, some of the relevant hormonal players, are sort of like summarized in figure 2 of the article. And we see that hypothalamus produces a thyroid releasing hormone, which acts on the anterior pituitary gland, which produces thyroid stimulating hormone, which in turn acts on the thyroid gland and produces the two hormones of T3 and T4. And T3 and T4 are the two primary thyroid hormones, and they are responsible for regulation of metabolism and protein synthesis. So they have these very important physiological roles to play. The notion that abnormalities of thyroid hormones may be implicated in major depression was presented pretty early on, because there was this clinical recognition that people who have deficiency of thyroid hormone demonstrate a lot of substantial depressive symptoms, and that these depressive symptoms, as well as some physical symptoms such as physical slowing and physical retardation, psychomotor retardation, that resemble the symptoms that are seen in major depression. So there was this early wave of studies which was looking at sort of like trying to find the ways in which thyroid hormones might be abnormal in major depression. And the overall body of literature that has come out suggests that there's a link between those two, but the link seems to be somewhat complicated, somewhat non-specific. And like I said, it's pretty well recognized that people who do have established and clinical deficiency of thyroid hormones, they do demonstrate depressive symptoms. But if you look at the general depressed population and you do studies of them, then it's only a very small percentage of people in which there is an obvious deficiency or an obvious dysfunction of thyroid hormones. There are some subtle changes that can be detected in some of the other patients with depression. So for example, patients with major depression tend to have TSH levels that are in the higher normal range. But again, these are average findings over depressed patients and control groups, and these are certainly not predictive, and they're neither sensitive nor specific. Similarly, there have also been findings reported regarding low T3 levels, elevated reverse T3 levels, blunted TSH response to TRH, and there's also some work on looking at thyroid-related antibodies. And again, sort of like this body of literature suggests that there is some sort of a subtle and nuanced link, at least in a subset of people with depression, but nothing that would indicate that thyroid dysfunction is involved in major depression on a routine level. Given that these links were being found in studies, so several decades ago, psychiatrists started using thyroid hormones as a treatment strategy. They started administering T3 or T4 to psychiatric patients, primarily depressed patients, to see what sort of improvement may be experienced. And the way these studies were conducted, there are two main study designs and two main therapeutic purposes. The first one is what we call acceleration of antidepressant effect when it is used with tricyclic antidepressants. So basically, it is well recognized that antidepressants in most depressed individuals take about 3 to 4 weeks to begin to have clinically meaningful effects. And there have been efforts to try to see if we can accelerate the onset of the antidepressant effect and have those therapeutic benefits early on. And the studies that have been done with tricyclic antidepressants show that if you start giving thyroid hormone as you start the tricyclic antidepressant, then on the whole, the onset of the antidepressant response seems to be earlier. So in general, the studies that have been conducted, they sort of like began to see patients start getting better within the time frame of 7 to 14 days versus the time frame of 21 to 28 days that you would see without these hormones. The second purpose for which these thyroid hormones have been studied are those individuals who have had a trial of an antidepressant medication, but they have not experienced benefit in their depression from that first trial of that antidepressant. So there have been attempts of adding on thyroid hormones as an adjunctive agent to see if that helps. And these studies have been conducted mostly with tricyclic antidepressants, at least the double-blind randomized control trials. And there is some trial data with newer antidepressants as well, but that's not necessarily double-blind or a randomized control format. And what the study suggests is that using thyroid hormones as an augmentation agent in people who have treatment-resistant depression does seem to be an effective strategy. That there's a subgroup of people, about 25%, who experience remission of their depressive symptoms once thyroid hormones are added on as augmentation agents. Now, in general, the way these studies were conducted, you can sort of like consider a first wave of studies, which was done with thyroid hormone and tricyclic antidepressants, and then a second wave of studies, which was conducted with the newer antidepressants, such as SSRIs. And when it comes to therapeutic issues such as acceleration of antidepressant effect, you see this somewhat odd divergence that the existing trials seem to suggest pretty strongly that there is an acceleration of antidepressant effects with tricyclic antidepressants. But at the same time, the research trials also suggest that there is no acceleration effect with the newer antidepressants, such as SSRIs. And we still don't understand why quite this is the case. Why is it that we're seeing these therapeutic effects with one class of medication and not with another? So that's a finding that's somewhat odd and that hasn't been fully explained yet. I would comment here that psychiatric clinicians have been using thyroid hormones for many years now, because the use of thyroid hormones for depression has become a part of many different recommendations for many different agencies. And the manner in which thyroid hormones are sometimes used in clinical practice doesn't always necessarily reflect the ways in which research studies were conducted. So most of these research studies, for instance, used fixed doses of thyroid hormones, usually either 25 microgram or 50 microgram, versus in clinical practice, when thyroid hormones are used as augmentation agents or otherwise, clinicians are often looking at TSH values and trying to titrate the dose based on what the TSH value is going to be like. So for example, in American Journal of Psychiatry in 2018, there was a case discussion published by Cohen and colleagues in which they shared their experience that when they use thyroid hormone augmentation, they try to aim for a target TSH of 2 milliunits per liter or less. And these sorts of approaches have not yet been studied in rigorous trials yet.
Well, if you would permit me to give a rough summary of our discussion so far, it seems kind of like the state of things is there's a lot of intriguing, suggestive findings, but yet we're still on a search for some clarity. And then what I want to do now is move to the third system and discuss what is the relationship between the HPG axis and major depression, and how does this differ between men and women?
Well, we chose to discuss the HPG axis separately in men and women because even though they both have, a driver in the hypothalamus and the pituitary, other than that, they're pretty different. The main hormones in the ovarian system that we think about are estradiol and progesterone. I think this is one of the most interesting systems. So we know that the HPG system is important just from clinical data. So there's a gender difference in depression incidence that starts at puberty and sort of dissipates by menopause. So there's something about those reproductive years that increases the risk for MDD. As we talked about before, there are various periods either within the monthly cycle or across the lifespan that also confer an increased risk for MDD. So things like the postpartum period where there's really significant fluctuations in ovarian hormones. The actions of these hormones are really important for obviously reproductive functions, but they have complicated and frankly very cool effects in the brain. I think my first neuroscience memory as an undergrad was looking at Catherine Woolley's work, looking at hippocampal plasticity after estrogen. So we all know that the hippocampus is a really important area for working memory and for depression. And she showed that estrogen really tightly regulates dendritic spine density. So times of high estrogen, you get this beautiful blooming of dendritic spines and all the cognitive benefits that come with having high connectivity in that area. And then those kind of shrink back down during low estrogen times. And I remember just thinking it was so wild that these were changes that were happening over a short time scale in myself and in every woman that I knew, and just speaks to the plastic potential of these kinds of compounds. So estrogen is one really important compound. And then the other is progesterone, and not just progesterone, but its metabolite allopregnanolone, which has gotten a lot of attention lately. So the enzyme 5-alpha reductase can convert progesterone to allopregnanolone, and allopregnanolone is in a group of compounds that are considered neuroactive steroids. And the function of allopregnanolone is that it actually acts as a positive allosteric modulator at GABA A receptors. So you might think about, okay, what are other positive allosteric GABA A modulators we use in psychiatry? And benzodiazepines probably immediately jumps to your mind. And so the anti-anxiety effects and also purported antidepressive effects in animal models of allopregnanolone really got people interested and have certainly moved pretty far down the road to translation. So two areas that allopregnanolone has been investigated are in postpartum depression and in PMDD, or premenstrual dysphoric disorder. So in postpartum depression, which is a significant problem and has very real ramifications both for the mother and for mother-infant bonding, there's really rapid fluxes that happen. So after the very high levels of progesterone and allopregnanolone that are happening during the pregnancy, once the child is born, those hormones rapidly fall off. I can imagine your brain sort of gasping, like, where are all the hormones that I'm used to seeing? And so the idea is that allopregnanolone, or its synthetic cousin, brexanolone, which was recently FDA approved for postpartum depression, acts to stabilize that system, particularly at extrasynaptic GABA receptors. So brexanolone is actually given as a 60-hour infusion and sort of gives a softer landing pad, if you want to think of it that way, versus the really abrupt changes in allopregnanolone that the brain is seeing at that time. So that's one really exciting therapeutic that's come out of this area. And then the second application that's relevant to this system is in PMDD. And PMDD is kind of an interesting contrast to postpartum depression. So postpartum depression makes sense. We want to increase allopregnanolone activity. And that makes sense with the idea of it being antidepressant or anti-anxiety. But in PMDD, we're actually looking to stabilize or block the conversion of progesterone to allopregnanolone. And that's sort of this interesting idea about the hypothesis of PMDD. So this is during the last sort of 5 days of the cycle before menses, where you're having a big ramp up, basically, of progesterone and allopregnanolone. And the idea is that while you would think high levels of allopregnanolone would sort of relax everyone, there's this idea that perhaps there's a paradoxical response to allopregnanolone in patients that have PMDD. And we've heard about this idea of paradoxical responses to GABA-A modulators before. So for example, paradoxical responses to benzodiazepines, either in young people or geriatric patients, or just folks that for whatever their sort of individual physiologic reasons have, rather than a relaxing response to a benzodiazepine, have sort of an activating response. So a hypothesis for PMDD is that there's sort of an activating rather than relaxing response to allopregnanolone. And so a treatment would be to sort of block or reduce the surge that naturally happens at the end of the cycle. And so studies using modulators of alpha reductase to do just that have shown really promising initial data. So the HPG system in women is a complicated system, but certainly has proven so far to be a worthwhile target in terms of novel therapeutics.
When it comes to men, the major hormone in the HPG axis is testosterone. And testosterone is basically is produced under the hormonal regulation of LH, which stimulates Leydig cells to produce testosterone. But aside from that gonadal production, there's also a small amount of testosterone that is produced directly in the brain, and which may play some physiological role as well. And testosterone acts on nuclear receptors to regulate gene expression. So there has been a lot of interest in looking at abnormalities of testosterone, its levels and its functioning, and the relationship to major depression. And similar, in line with the theme of what we have discussed before, it's pretty well recognized that people who have a clinical deficiency of testosterone, they tend to demonstrate depressive symptoms. However, if you look at individuals with depression generally, most of them do not show any abnormalities of testosterone. However, there are links that suggest that relationship is more complex. So for example, there are studies which have shown that men with major depression have lower levels of testosterone compared to non-depressed individuals controlling for age, even if those levels are technically within the normal range. And it's also been shown that people who might have levels of testosterone that are in the lower normal levels of range, they might have a higher risk of developing depression in the future. But as far as the state of the research goes, these findings are not strong enough that we can recommend routine screening for testosterone levels in depressed patients in absence of other clinical signs or symptoms of hypogonadism. There are a lot of research trials that have looked at examining the relationship of testosterone as a therapy and its effects on mood. And in fact, there have been 3 meta-analyses that have been published over the years. But if you look at these meta-analyses, and the most recent of these meta-analyses was pretty large and included 27 randomized control trials, but only a small number of these trials have actually been conducted in people diagnosed with depressive disorder. So for example, in the meta-analysis that I'm referring to, out of the 27, only 8 trials had been conducted in someone with a depressed diagnosis. So even though these meta-analyses overall may show a positive relationship between testosterone therapy and mood effects, and they generally do so with a small effect size, can't necessarily generalize the results of those meta-analyses when you're specifically talking about individuals with major depression. So in order to do that, we have to look at the trials which were specifically conducted in that population. And in that particular area, there was some early small pilot trials which showed that testosterone had a pretty large effect on depressed symptoms in individuals with treatment-resistant depression. But subsequent larger studies that were done, and there are about 4 to 5 trials that have been done subsequently, the results of those trials were disappointing, and they failed to replicate that large effect size that was seen in the early initial trial. So at the moment, there's a general sort of skepticism in the field that when it comes to major depression, especially treatment-resistant depression, treating it with testosterone in the absence of identified testosterone deficiency does not seem to have therapeutic benefits. However, there is some emerging literature that for those individuals who have what is called subthreshold depression, or they might have what is called dysthymia. That is, they experience depressive symptoms, but they're not severe enough that we would call them major depression. There are 2 small preliminary trials that have looked at testosterone use in that population, and the results indicate that there might be benefit. But again, these are still rather preliminary findings and not something that we can state with great confidence.
Thank you both for these overviews. And now that we have a better understanding of these 3 systems, I'd like to review the different kinds of hormonal interventions that have been used to treat depression. And we've already touched upon this a bit during this discussion, but I'm looking specifically at Table 1 of your article, which has an outline of the evidence for hormonal treatments. What can you tell us about the efficacy or drawbacks of these kinds of treatments?
Sure. Well, we love Table 1. Table 1 really distills, I think, the main points of the paper, starting with CRF1 antagonists in the HPA axis system. There's really been strong evidence that there's no benefit at the human level, despite the really promising preclinical data that preceded it. So that's a pretty strong recommendation that, at least broadly in MDD, this is not a useful strategy. The other strategy that we cover in the HPA section are glucocorticoid receptor antagonists. And the best studied of those is mifepristone, particularly in the population of MDD with psychotic features. And there's actually moderate evidence of a benefit specifically for the psychotic symptoms, more so than the mood symptoms in MDD with psychotic features. But the caveat is that it seems like plasma level is really important in those studies. So getting above a minimum plasma level to get that benefit. So what's really needed is sort of a prospective study that's specifically making sure that people get to that minimum therapeutic dose and examining whether the findings hold in a larger trial. Some of the downsides to mifepristone include GI symptoms or headaches, but it's generally well tolerated and has kind of a cool dosing protocol where subjects are treated for 7 days with the compound and then are assessed at 1 week or 28 days or even 56 days and are still looking for benefits. So it's kind of an interesting model where there's a limited treatment period, but the benefits extend further on. So that's definitely an area that we think future research will be interesting to follow.
When it comes to thyroid hormones, T3 has been studied more rigorously in psychiatry in various randomized placebo-controlled trials versus T4, which hasn't received a lot of attention in research studies. With regards to use of T3 as an augmentation agent in treatment-resistant depression, there is overall moderate evidence of efficacy, particularly with regards to tricyclic antidepressants. There's a good amount of literature there suggesting that these medications are helpful. However, the caveat here is that the efficacy of augmentation with newer antidepressants, such as SSRI, needs to be demonstrated in placebo-controlled trials. At the moment, the support for efficacy in newer antidepressants mostly comes from STAR-D, which did not have a placebo arm. When it comes to using T3 for acceleration of antidepressant effects, here there's a divergence again between antidepressant medication classes with regards to using T3 for acceleration with tricyclic antidepressants. The evidence overall is pretty good, and this is something that guidelines do suggest that can be helpful. However, when it comes to looking at acceleration effects of T3 with newer antidepressants such as SSRI, the existing trials demonstrate that there is no acceleration effect, and hence the use of T3 for acceleration with SSRIs cannot be recommended at present. In terms of safety issues and side effects, overall, the use of T3 in research studies have been safe and tolerable. The minor side effects such as sweating, tremors, nervousness, and palpitations have been reported, but generally have been of limited severity and have been well tolerated. However, there are some potential long-term impacts that can happen with long-term use of thyroid hormone. So, for example, it's believed that long-term use of thyroid hormones can possibly induce bone resorption, leading to an increased risk of fractures. So, it's recommended that bone density be monitored every 2 years in postmenopausal women if they are being treated with thyroid hormones on a long-standing indefinite basis.
So for the HPG section, we've touched a little bit on allopregnanolone, both stabilizing it in PMDD and enhancing it for postpartum depression. And these are two really exciting areas to follow. So in terms of postpartum depression, there was recent FDA approval of brexanolone. So there's pretty strong evidence of efficacy there. The worries that we have about brexanolone are some of the side effects that are most likely related to its therapeutic action at GABA-A receptors. So things like sedation or syncope, and those concerns about falls or syncope have led FDA to recommend a REM system for the use of brexanolone. So that's one limitation there. And the other is more of a practical limitation. So this is a 60-hour infusion. So you have to think about, where is this happening? Who's administering this? Who's holding the baby during this time? So I think a lot of centers that are starting to use brexanolone are trying to work out some of the practical challenges. But the science and the efficacy data are very exciting. There's also some ideas about using allopregnanolone modulators in MDD and experimentation with oral versions of these compounds. However, those studies are really in their early days. Recent data came back for the oral compound in MDD that did not meet the primary efficacy outcome, although did have some good antidepressant effects at earlier time points. So this is an area that's still under active development and worth watching.
When it comes to testosterone, overall, there's pretty good evidence that if we are dealing with individuals who have clinical hypogonadism and they are experiencing depressive symptoms secondary to clinical hypogonadism, then testosterone replacement therapy has a great effect in relieving those depressive symptoms. When it comes to looking at use of testosterone in treatment-resistant major depression in individuals without clinical hypogonadism, then the existing research tends to suggest pretty strongly that there is either no benefit or the benefit is pretty minimal. Versus when it comes to the use of testosterone in subthreshold depressive symptoms, in men without clinical hypogonadism, then there is some preliminary evidence that there might be benefit, but this is yet to be demonstrated in larger trials with more robust samples. And with regards to the some of the possible risks with long-term use of testosterone, it's been known that the long-term use can increase risk of prostate cancer, polycythemia, and venous thromboembolism. So if there is clinical concerns for these conditions, the use of testosterone as an antidepressant agent is not recommended.
We've gone through a lot of information here. So are there any overall conclusions that you can make as to the utility of hormonal treatments for major depression?
So I think we do have some actionable items from this work. So thyroid hormone is one area where there's a solid data set and some scenarios where it certainly makes sense to proceed with use. I think allopregnanolone is another area that's very exciting to follow and also is sort of in the treatment space, clinically available at this time. I think another area that we haven't talked about so much on the podcast is the idea of using estrogen replacement therapy in perimenopausal women who are also having physical symptoms of menopause. So there certainly are some actionable areas. And then our hope was that we would get people excited to sort of follow this literature. It's a really big literature. It covers preclinical and clinical and translational work. But there are several compounds that are in the pipeline, and we hope that we just got people excited to keep reading.
Now, if I were to be asked for a main message of our discussion, I would basically say download table 1 for easy reference for the summary of evidence. But more importantly, what would you say are the main messages that researchers, clinicians, and other mental health professionals should take away from your work?
I would agree with you that Table 1 is a pretty handy resource, and when we were making Table 1, our hope was that could provide like a quick snapshot of the current state of evidence and recommendation when it comes to the use of hormonal agents. So we would definitely encourage readers to look at that in detail and to refer to that as needed. I would further echo Dr. Dwyer's with regards to the prior question. Our hope was to convey to the readers, both clinicians as well as researchers, that this is a very promising area of inquiry, that we have a large amount of research literature that deserves to be studied, that deserves to be looked at, and there are already some actionable findings that are relevant for clinical practice, but also there are also a lot of clues for future research. So we just basically wanted the psychiatric community to become mindful of the use of hormones in the treatment of depression again, and just to be kind of aware of the existing evidence base.
And finally, with regard to this being a promising area of research, what are some recommendations you have for further research in this area?
I think one area that stood out to us is the idea of trying to take a more personalized medicine approach or to look for enriched populations for certain endocrine abnormalities. So I think at the start, we talked about how depression is this really heterogeneous syndrome, and there's probably multiple disease entities that are kind of floating around under this construct. So one research strategy might be trying to sort of before the trial enrich for certain endocrine abnormalities such as hypercortisolemia in certain MDD patients, and then testing these hormone-based therapies specifically in populations along those lines. And I think that's consistent with just some of the approaches in depression clinical trials in general, trying to look for a more personalized approach that we hope ultimately will translate to a personalized medicine approach in the psychiatric clinic.
I would add to that I think future trials also need to take into account the experiences of clinicians when it comes to using these hormonal agents. So for example, I mentioned previously when I was talking about thyroid hormones, that the experience of clinicians has been that when we're using thyroid hormones as augmentation, it makes sense to target a certain TSH level and try to bring it down below a certain value. Versus if you look at the research trials that have been done of thyroid hormones, they've all been conducted using somewhat fixed doses of thyroid hormones. So one of the things future researchers can do is that consider these different trial designs in which we can introduce some of the flexible dosing that clinicians have used in their clinical practice in the use of these agents.
Dr. Jennifer Dwyer and Dr. Avias Aftab, co-authors of a review article in our August issue on how the neurobiology of hormonal systems adds to our understanding of depression. Thank you both for speaking with us.
Thanks for having us.
This concludes this episode of AJP Audio. You can rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. Please also visit our website, ajp.psychiatryonline.org, to check out trending articles, find CME courses, and watch videos highlighting some of our other articles. APA Publishing has other podcasts you can listen to. Psychiatry Unbound is the books podcast from APA Publishing. It's hosted by Dr. Laura Roberts, editor-in-chief of APA Books. Also check out From Pages to Practice, which reviews the latest research published in the journal Psychiatric Services. It's hosted by Dr. Lisa Dixon, editor-in-chief of the journal, along with Dr. Josh Beresin. You can subscribe to these podcasts on Apple, Google, Spotify, or on any of the popular platforms. Next month in AJP Audio, we'll talk with Ms. Emily Robertson of Louisiana State University about her research on the relationship between callous unemotional traits and the risk of gun carrying and gun use during a crime. We hope you'll join us too. Thank you for listening.